include ongoing rounds development at the Royal Free and psychological consultation to staff support service at South London and Maudsley NHS Trust. Her recent book, True Tales of Organisational Life, considers the unique challenges and rewards of working in healthcare and draws on real-life stories of using psychology to manage the impact of healthcare work and to build staff resilience. Her book concludes with 7 true tales, which explore the creativity through which healthcare staff help patients and families manage the emotional challenges of being ill and being hospitalised, coping with the loss of a child, and placing their trust in healthcare teams. So I have no doubt that her presentation will be of enormous resonance to all present. Thank you, Barbara.
Thank you very much, Maria, and thank you, Anna, and everybody from Children in Hospital in Ireland for inviting me here today to speak. As I was on my way in on the Lewis, I was thinking this is actually my old university, Trinity, so it's very nice to be back here speaking. Anna and I spoke a bit about what would be a good topic to focus on, and we're very conscious of the fact that there's a mixture of people in the audience, probably with a range of roles and experiences and relationships to this theme of resilience. And we thought that that would be a good focus to think about what is the, what's the reality of working with children when they're ill or caring for children when they're ill. And as Maria has described, I've worked in healthcare for about 25 years now in a range of different roles. And I'm very interested in thinking about the impact of work on healthcare staff and what's happening both above and below the surface at work. And you'll see from the presentation that that's what I'm going to talk about. And what I'm hopefully going to be able to do is to think about what is the challenge like of keeping children in mind in different roles in healthcare organisations. Can everyone hear me? No. Yeah. Okay. Is that better? Okay.
Additional one.
Okay. Is that better? Is that better? Yeah. Okay. 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 So if you can't, just let me know. So so let me just give you an overview of what I'm going to cover. I want to just tell you a little bit about my context, and just a little bit more about, not in detail about the work I've done, but in terms of what I've learned from the work I've done and how that's informed my thinking about looking after sick children, and particularly to think about the importance of task and also the importance of context and meaning in healthcare work. And I wanted to think about 4 different contexts. The first of those is the context of staff experience in healthcare, because although there's a lot of discussion at the moment about burnout in healthcare staff, worries about healthcare staff, there's actually an incredibly good evidence base for how to take care of staff in healthcare settings. We know what we need to do. And so I just want to cover some of those models. And then the second context is thinking about illness in a family. What is it like to be a sick child, and what is it like as a parent to have a sick child? The third context is to think about the experience of work in terms of relationship, and particularly the relationship to role. And then the fourth context is moving to thinking about what's happening below the surface at work. So thinking a bit about the shadow side of healthcare work. We all know there's a lot of attention being paid to compassion in healthcare systems, particularly in the UK and Ireland. And that one of the reasons why there is so much concern is that there's worries about cruelty in healthcare systems in the UK and Ireland. And so I think thinking about the shadow side of organisational life is very important. And then I want to finish to thinking about resilience and about self-care and self-compassion. I've kind of planned the talk as a walk through the models and frameworks that I use in my work that I found very helpful to my understanding of what's going on. Maria has described the work that I do, and lately I've started to work with a consultancy. We work with medical teams when things have gone very badly wrong. When maybe the CQC in the UK have been involved, there's been a serious incident or a never event. And we come in as psychologists thinking about how could we formulate this problem and what needs to be in place to avoid problems happening in the future. And that's very much informing what I'm describing tonight. But I wanted to start with this picture first, because I think it's very helpful when you think about what work you do and why you chose the work you do, to think about what you bring to the work. Home is where we start from, is the title of a book by Donald Winnicott, who's a child psychotherapist who did a lot of work on parenting, good enough mothering and attachment. And the reason why I'm starting here is that all of us, it's stating the obvious. We were all once children. We were all once cared for. Those experiences have influenced us. They influence our expectations of caring. Some of us may have had experience of being ill when we were young, or having a sibling who was ill. All of those experiences are significant. And they are the internal world that we bring into our work. And they are the internal world that we bring into our choice of our career, and how we relate to our career. And that's a relationship that might change over time. And I think the task, given that there's probably lots of different roles in the room, the task is keeping the child in mind. Some of you are smiling, so maybe you know this picture, or maybe you even took this picture. I found it on Twitter, and it did beg the question, and I'm happy for anyone to answer the question about who owns the picture. I hope it's okay to use it. I think it's a Temple Street picture. Crumlin picture, okay. Okay, so this is a Crumlin picture, which I thought is a really good example of keeping the child in mind. So this was taken, and please tell me if I've got it wrong, during the snow, I presume. So this is a child who was in intensive care, and the nurses and doctors on the ward brought snow in to the child so that she could make a snowman. And I think it's a lovely example of really good, kind, creative care. But it's also a very good example of the challenge in caring for sick children. About how do you continue to treat them and look after them while keeping in mind that they are still children that have children's needs, and they're still developing. So they have both a very serious thing happening to them and the need for something playful to happen around them at the same time. And that is not an easy task to keep in mind. And in my experience of seeing people who came to see me in the psychology service, people often, when they come for therapy or they come for coaching, they come with a very linear description. They might come with a description of failing at their job, or not doing it very well, or being very distressed. And I was very interested in trying to unpack that and think about, was the role helping them to keep the task in mind? How easy or hard is it to look after children in situations like that? What is it like trying to get into work in the snow when some children need operations, and also to look after other needs of children? So just want you to keep the idea of task in mind as I go through the presentation. So just to tell you a little bit about me, because that's the first context, I guess, the context that I'm coming from. A good long time ago now, and I deliberately call this Once Upon a Time, because a lot of my interest in psychology is around story. But a long time ago, I started working at the Royal Free in a very interesting role. It was a full-time role, and the remit was to provide psychology just to the staff of the hospital. And it was split in half. So it was 50% clinical, which meant seeing people individually for therapy, and 50% organisational. So from the beginning, there was a licence to move upstream, to look at problems that were coming through, and to think about, could that problem have been prevented? Sometimes you would see the same role, different person, but the same role being referred back to you again and again and again. You'd think, why doesn't someone think about designing this role differently, or providing some support for this person, or doing something differently with this team? So it was a really, really good opportunity to think about what psychology can bring to healthcare contexts, and to listen to stories, even the stories that we were told in therapy, and to hear them as stories about that person's job, the family they came from, and their organisation. So to be paying attention to the different levels of context at the same time. And I work very systemically, so always thinking about the individual in context and using narrative psychology models. And as Maura mentioned, about 8 years ago, the Royal Free became one of the pilot sites for Schwartz rounds. Some of you will know what they are, some of you will already be involved in them here. I know they've just been launched. And they're a once-a-month meeting like a medical ground round, where a team present a case, but instead of discussing the impact of the case, instead of discussing the treatment of the case, they discuss the impact of the case. And I was very interested in thinking as a psychologist about that process and about how you help people to bring the stories that they were only telling me in private into a more public space, but safely. So that led me to think a lot about what's seen and unseen in healthcare organisations and the benefits of creating safe spaces where difficult experiences can be talked about, as opposed to denied, split off, or hidden. So I think context is everything, and it's really important in terms of thinking about the impact of work to think about what is the context in which a problem has been experienced or a success has been experienced. So I want to think about just firstly the first context, which is working in healthcare, before going on to the second one, which is working with children. And I think most of us who work in healthcare know that for lots of people, it's a game of survival now. There's a lot of emphasis on well-being. For lots of people, the work is getting tougher, and the volume of work is getting heavier, and there's a lot of being pulled towards needing to be reactive and wanting to have more time to think. There's been a lot of very interesting work done on nursing, children's nursing, looking at moral distress in nursing, which is where nurses are stressed because they feel that they're not able to spend time with the children. It's not the kind of volume of the work, it's the fact that the thing that they went into the work to do, that it can't do as much of, and they go home feeling as if they haven't been able to provide care in the way that they really wanted to and that would meet their values. So lots of people feel like they're surviving more than thriving. And we know that there's a lot of different influences on that experience. Healthcare is a massively political context. A lot of my experience is in the UK, where the NHS is a very political hot potato continually, and particularly now. But equally in Ireland, and in Ireland, I think the context of trying to organise public sector, the health system, trying to get the balance between public and private in Ireland and in Dublin, and I don't know that much about it, but I know there's a lot going on in terms of reconfiguration of children's hospital services. So that is a context, I would imagine, of a lot of turbulence. At the same time that people's expectations of healthcare are increasing, sometimes unrealistically. And we also know that the work is inherently stressful, and there is some evidence that the very things that make people drawn to healthcare work can make them a little bit more vulnerable. Sensitivity to pain, to vulnerability, the need to give, all of those things, without the right support, without self-awareness, can lead to trouble. So put simply, I'm just going to go through a couple of different frameworks. I'm sure some of these are familiar to you. So we know that work environments can cause stress. And we also know that we know the worst kind of job. And the worst kind of job is a job that's high in demands, low in control, and low in support. And study upon study has shown that, and the big studies, for those who are interested, and I'm sure a lot of you know about the Whitehall studies in the UK, which have shown that those kind of jobs predict heart disease and depression. And they've been replicated in the States. We also know that the amount of stress is affected by the person who's exposed to the stress. But the effects of stress can be reduced by increasing control and support. And I think that's very important in healthcare, because I work with a lot of managers who are very conscious of the fact that they can't reduce people's exposure to the volume of work. They can't, they're being asked to get people to see more patients. So there aren't that many options in terms of reducing demands. So the areas to be focusing on really are people's sense of control over work and the support that's available to them. And that support can mean lots and lots of different things. It can mean challenge, it can mean space to process the work, and it can mean practical support. And this is another framework really to think about staff experience, and I'm building on the frame, as you can see that. So the experience of work depends on the person in the job, the role. We know that good role clarity protects people's mental health. And poor role clarity is not good for people's mental health. And that doesn't just mean me knowing what my job is, it means me knowing where my job ends and your job begins, and vice versa. So being clear about the boundaries of work and the relationship between roles is also part of role clarity. And it's interesting, you know, some of the organisations that I get asked to go into, there's a confusion about both role and task. So people present as stressed and they're identified as problematic. But sometimes it's much more useful to look at the way the role has been designed and the clarity within the team around the role. And I'm sure that resonates with lots of you. We also know that good teamwork protects mental health. We know that even in toxic organisations, people who work in well-led teams will be protected from some of the toxins of the work. And there's a few reasons for that. One of them is that well-led teams usually do have role clarity, and the other is well-led teams usually have more of a sense of control over their work. And Michael West is a name, for those of you who are interested in, I know he's been in Ireland and done some talks, who's, you know, his is the definitive evidence base really on teamwork in healthcare, where he's linked teamwork to morbidity and mortality rates in hospitals. And so hospitals with better teamwork, better designed systems have better outcomes for patients. It's simple. We also know that job content is very important, and we're quite poor, I think, in healthcare. In other industries, we're better at rotating people out of jobs that will expose them to harm. You know, for example, there's a big difference between working in paediatric intensive care and adult orthopedics. But we don't decide that let's rotate these people. Let's make some changes so you're not constantly exposed to trauma. And we also know that management is important, and equally, management style is protective of mental health in staff. So there's lots of good evidence for all of these, and also for the impact of organisational culture. And I think it's really helpful to think about our experience of work in terms of a relationship, to separate out the person from the role and the system. And I use this a lot in not just consultancy work, but also in therapy work and coaching work, because I think it's really helpful for people to think about, what do you bring to your role and what does your role do to you? How much is there a good or poor fit? How is the system designing the role, and what is the role doing to the system? And this is a kind of constantly moving picture, it's not static. And in times of big change, like, for example, maybe Children's Hospital Services now in Dublin, none of these elements probably are static. So what's keeping people safe and clear and able to think? So another way of thinking about some of these models is to frame them positively. And this is turning some of those models into positive. So we know about the 6 elements that make for good work design and healthy work design. And that's jobs where there's a sense of commitment, control, and challenge. And that the opposite of those are alienation, helplessness, and fear. Because challenge is physiologically the same as fear. It's just interpreted as a positive experience. And also where there's coherence, creativity, and contact. And when I was doing a lot of work with healthcare staff who were coming to see me for therapy, and some of them would have, you know, we know about 1/3 of NHS staff at the moment are at clinical rates of depression and anxiety. That we know that's the figure. But lots of those people are still in work. And I would ask them, you know, what's brought you to work today? How have you managed to get out of bed? And they would inevitably say their patients. And managers often missed the patient contact. And sometimes clinicians who've moved into management roles started to suffer because they didn't have that contact with patients. And I think actually with Schwartzrands, they loved getting to hear the stories that they weren't in contact with anymore. And I think that that's because there is creativity in the relationship. There is a chance for contact and relationship. And the other thing that we know really helps us to manage stress is a sense of coherence. And I really like this slide because I also think that this is what our patients need. So this is what children need, and this is what parents need. Even if the prognosis isn't good, even if a child is very, very ill, in the moment, a sense of what's happening, a sense that people are creatively working, and a sense that they're not on their own. And that's, I won't go through all of that, but a good definition of a sense of coherence. And there's a psychologist called Antonovsky, and he's written a lot on resources models of stress. So just rather than looking at, what stops you from getting stressed, what helps some people to stay resilient. And I think sense of coherence is a really interesting idea to keep in mind. So the psychological challenges of healthcare work are to stay in touch with the meaning of the work without being overwhelmed by it while staying in row. And written like that, it looks like quite a simple thing, but it can be, as we all know, a much more complex thing. And what helps us to do that is to feel that we are contained. And by that, I mean a sense of psychological containment, so that we feel that somebody is keeping us in mind, that if we are working with a very ill child or a very distressed child or a very distressed relative, somebody is keeping us in mind. There is somebody who will listen to us talk about that work. There is somebody who's helped us to know what to do in that moment. And if we become very anxious or if we become very distressed, there's someone who will help us to manage those feelings. Without a sense of containment, eventually what will happen to people is that they will become flooded by the feeling and unable to think. And then it's very difficult to stay on task. And then you get problems with the team. So that's the first context, the context of working in healthcare. And I wanted to really draw on that and move now to the second context, which is why we're all here tonight, which is thinking about children in hospital and thinking about working with sick children. And really, I'm sure this is, hopefully this is very familiar and captures the experiences that you're having, linking it maybe to psychology models. So we know that the impact of ill health in children can be quite wide-ranging, depending on the problem, depending on what's wrong with the child, depending on the prognosis. It may produce trauma for the child in the family system, the family having to readjust their expectations, what they thought was going to happen to the life of that child, to the life of that family. It also will be impacted by the child's ability to understand what's happening and the need for the parents to be supported to understand what children at different ages can take on board. The threat to the sense of safety, everything about caring for children and being a parent is helping children to feel safe, helping children to go to bed, helping children not to be scared of the dark. Being a parent of a sick child is helping the child to feel safe when they may realistically not be safe in the way you would hope they were as a parent. Other impacts, the belief in a just world, changes to identity, fears about the future and the relationship to the body. I was thinking about this when I was doing the presentation about working with a woman whose child was disabled and in a wheelchair, and she described she became quite depressed, and she talked about her daughter reaching puberty and starting her periods and having to kind of help her at that stage of the adjustment to her body when the daughter had a disability that she had never had. That experience of helping a child relate to something that you have not had to relate to and to a different future. Really, really sad, difficult experience. And we know that the impact of ill health on children will also depend on the pre-existing personality of the child and their carers. So the impact on the staff depends on the content of the work, the meaning of the work, the context, which will influence the intensity and the speed of the variety. What are the emotions aroused by the work, and how much time is there to pay attention to them and to process them? How much time is there to deal with unwanted feelings? I worked in a children's hospital in the UK, and we did a Schwarzschild. I thought it was a really clever idea. It wasn't mine, it was the hospital's idea. They did a Schwarzschild on bad smells, which sounds really, really odd, but I thought it was brilliant, and it gave people an opportunity to describe how awful it feels to be revolted by a sick body or by a sick child and have to hide that and go in and work with the family and what that really feels like. So those kind of feelings that it's not very nice to have to admit to and own up to. which link to people's ability to be intimate and stay close to children and their families, and the distance they need. And all of us need both in the work. But the psychological and emotional challenges of the work are predictable. So if you're a sick child, what do you need? And I think these questions help to think about what a sick child might need, you know, and all of them will be influenced by the age of the child, by the family system that the child is in. And in terms of thinking about the ideas that I was talking about at the beginning, the idea of role and task, these kind of questions help to orientate to what the task might be. And this is where role clarity again is important. This is what a child might need. What has the child already been given by who in the system? So what is it appropriate for me and my role to provide to that child? These might be all the questions that a child might have that would change over time. And psychologically, these are the kind of things that a child would need. Help me to feel safe, give me some control, know me. And that's why I thought the picture of the snowman was so lovely. You know, just giving a child an opportunity to play is actually a really lovely way of getting to know what that child would be like if they weren't in hospital. Help me not to feel overwhelmed. So understanding what information a child can take in and can't take in, again, at different times. And in some of the work, and I'm sure this is very familiar to lots of you, it's interesting working with family systems where maybe the parents have a completely different understanding of what the child is able to absorb. And the parents are worried about the child feeling overwhelmed and the child wants information. And that, I think, is another example just of the complexity of the work. Give me realistic hope, not false hope, and challenge me sensitively. But obviously for all of you working in these services, you're not just working with children, you're working with the parents of children and the family system. And I think if you think about what the parents of sick children need, I guess, and I'm sure we'll have time to discuss this when we have the question and answer discussion, the things that parents need are very similar to what a child will need. And I'm sure all of you, you know, in all the work that I've done, the more you know the patient, the more you know the families, the more you can read the signs of what people need. The difference, I think, for parents is that they need to help to cope with the threat to the role that a sick child involves, because having a sick child who's in hospital requires you to accept that the one thing that you want to do as a parent you are not able to do, which is to keep that child well on your own. That you depend on other people to do that. And that's something that really needs to be carefully managed, as I'm sure you're all doing all the time. So there isn't just the reality of what's been done, there's also the below the surface and what the meaning is and the symbolic roles. And I think that the more we understand and are aware of what's happening consciously but also unconsciously, the more we can have space to really think about what's the best way to provide care to a child and to a family system. And again, thinking psychologically, having a child who's ill and having a child in hospital is a very anxiety-provoking experience, it goes without saying. And we know that there are two ways that we manage anxiety. Conscious anxiety, but also unconscious anxiety, the things that mightn't be spoken about. And they are making meaning and attachment. So being able to make sense of what's happening to us, some understanding, even if it's an understanding that might change, but making meaning, and also through our attachments. Our attachments soothe us, they help us to feel safe, even if something bad is going to happen to us or to someone we love. And they are what help us to cope with very, very difficult circumstances. And these are, this chart is just describes the way in which we use attachment and the signs of how a child might be using attachment by staying quite close to somebody, by having a safe haven, a secure base, and children get very distressed if they're removed from their attachment figure. And I think what's sometimes difficult for parents with sick children is that children become quite attached to people in the hospital. and other people in the system. And that can be quite a difficult thing to manage. So there is a lot that can be done to help with the emotional challenges with sick children present, helping people and families to understand, re-establishing a sense of control, identity, think about what's actually happening in relation to current life roles, match information to style, and balance hope with reality, and maybe help with the management of loss and grief, which with a child with a poor prognosis is an ongoing process, not a finite process. So it's also, I think, really helpful to think about not just what you can do and what you can give to a child, but also what impact you're having. And it's really, I think it's good every now and then to kind of step back and think, what impact do I have on the children that I look after? And does it vary? And does it vary depending on what's wrong with them? And does it vary in terms of their family system? So you can make people feel loved and cared for, but you can also make them feel anxious and uncertain. You can make them feel clear. You can soothe them by touching and being close to them. And there is also a relational impact. So relating to them, as if you were their parent, as if you were their teacher. And I think in terms of resilience, it's a very helpful area to think about. And sometimes in some of the teams that I've worked with, people don't have that much space to think about how they're impacting on the people that they're looking after. And they're sometimes surprised when they get feedback. And that brings me to this idea that I wanted to just flag up for a minute in terms of thinking about resilience, which is reciprocity. I'm really interested in thinking about this and just thinking about not what we want to do in our work, but what we need from our work. And I think the picture shows this idea, this idea of the hand that's drawing the hand, that's drawing the hand. This circular idea that we choose an area of work for reasons, particular reasons, conscious and unconscious, that impacts on us, that shapes us. The way in which it shapes us influences how we relate to the work, that changes us, and so it goes. So it might be worth thinking about what impact does working with sick children have on you, and why you're doing that work, and what it gives to you. And it may be that there's very interesting literature in psychology on the desire to repair something in ourselves by choosing to look after other people. Working with children can increase your sense of control. Working in healthcare can improve your sense of self-worth. But it might also, and this could depend on different factors, make you feel frustrated and angry. It gives you an opportunity to express care and tenderness. It's always, when I work with stress, does it bring out the best in you or the worst in you? Do some children bring out the best in you or the worst in you? Why is that? Some families as well. What makes a difference to the above? And how often do you talk about that in your teams? Because I think when we think about children, we have, a lot of us, this kind of longing to care for children, probably for parents, for anybody who's working with children. There's this kind of longing, and this picture is kind of how we imagine. It's very idealized, this beautiful baby. It's very clean. It's asleep, smiling. It looks good, quite angelic. It's kind of what you imagine when you're longing and to express your own tenderness or desire to care for a child or have a child. And that's what we bring in to caring for children. And what we're often hoping for at an emotional level from our work, if we're working in healthcare, is resonance. And that idea of connection. We did not decide to go and work in a bank. We did not decide to go and work we chose to work in healthcare, which is really about relationships and wanting to care. And I like this definition about this idea of harmony and congruence, that resonance is the bonding that happens between a mother and child, and also between an owner and his dog, this feeling of connection, the unspoken, the knowing each other. And it's really the mechanism of love, and that's often what people are wanting to express in this kind of work. And when you're working with sick children, that is quite important to pay attention to, because that can expose you to some risk. Because they're not always the idealized child that we saw the picture of, and you know this better than I from your work. Children who are sick are in pain, and it hurts being close to children in pain. It's not nice. It's not a nice thing to have to witness. It is at the heart of the work, and it is what's having to be withstood in the work, and it hurts us. So there's pain, emotional pain, and the more it can be named and expressed and talked about, the more helpful it can be. So that's the complexity of the work. We're drawn to something, we hope for something, and we never fully get it. We get part of it, and then we get something else. We have to witness a lot of pain and hurt and loss as well. And if we don't pay attention to that complexity, I think we can get in trouble in the work. So it really helps to pay attention to the shadow side of the work. And we all have them. They are a necessary part of all of us. They allow us, our shadow side, our individual shadow side, allow us to deal with our own traumas, the trauma of the work, to kind of storehouse negative experiences. In professional roles, we can't be going into these settings and crying or being angry. We have to kind of put it away. But they do go somewhere in a shadow side of ourselves. And they go into organizations as well. And if we don't acknowledge them, then they can skew us, and they can skew us in our relationship to our work. And there are some unbearable realities, I think, in working with children. The reality of death and pain, of limits. Everybody can't get better, and some children won't grow up. And I've worked in a couple of different children's hospitals in the UK, including in Great Ormond Street. I'm very interested in how the shadow side kind of takes hold in organisations where, the difficulty of acknowledging this reality can lead to things like over-treating, not stopping, keeping going. And what we know happens in healthcare is the shadow side gets acted out in the relationships between colleagues, or sometimes in the family system. Because when we're tired or when we're exhausted, we come up against our own limits. And when you're working with children, it's very difficult to admit limits. And so we tend to deny them. But if we deny them, we're opening the door to cruelty and to the risks for the shadow side to play out in some way. And that's where you get teams, systems, cases where there's confusion, mistrust, a lack of clarity, conflict. It's very interesting looking at the cases in the UK at the moment where parents of sick children have gone to the High Court because of the difficulty of accepting limits, because of the difficulty in the system of, in some cases, supporting the medics enough to draw the line, the fear. And I think you could argue that what has happened in those organisations is some moving into the shadow side of the work and the difficulty of setting limits. And in the work that I do, I deal with this fallout of that. I know the distress that causes in staff and in teams and the trauma. And I think that unless we have space to process and feel and understand the complexity of the work and the impact of the work on us, we're always running the risk of those kind of situations occurring. Some of you would be familiar with this framework. If you're not, I would recommend that you read about it, because this is an example of working in the shadow side. So the drama triangle was developed by a psychiatrist who was looking at where relationship dynamics can go wrong, particularly in helping relationships, where you get, in relationships that should be adult to adult, you get as-if relationships. So two adults relating to each other as if one was a parent and one was a child. And they are usually very alive, where there is a difficulty in people taking responsibility for their feelings. So you get somebody who's a rescuer who interacts with a person who's a little bit more helpless. And then the persecutor, and if you think about some of the examples that I've just been alluding to in the UK, the person who's saying, no, we can't treat this child anymore, would be experienced as the persecutor, but they mightn't necessarily be the persecutor. They're just the person who's saying there is a limit. The rescuer becomes exhausted because they give too much for too long. And then the thing about the drama triangle is that the roles shift. And this is a really useful framework to look at in teams where relationships are going wrong and where people are getting burnt out and angry with each other. So to manage the complexity of the work, what we need are resources. We need emotional resources, physical resources, cognitive, to think through, problem solve, spiritual, and I don't mean a religion there, but I do mean it could be a religion, but also the ability to connect to values and beliefs. And in the work that I did nationally on Schwarzrands, one of the reasons why people I think really liked them is that they gave an opportunity to tell stories which connected them back to the reason why they went into healthcare in the first place. And I think there is an anxiety in the UK and probably here that organisations aren't, because there's such pressure to preserve finances, that they're moving away from some values, and that the clinical work is holding the values and managers aren't. And I think people need to feel connected to their values. So it's a really useful question in terms of resilience to think about what sustains you. And the basis of resilience is realism, and that's health for staff in the context of shadows, not denying that they exist, accepting that they will exist in every healthcare context, and even more so with children, where there is the dynamic of vulnerability. And there is our own vulnerability that we have had as children, that exposes us to risks if the drama triangle dynamics take hold. So to keep well and to keep the child in mind, it's important to pay attention to role, the positioning of the role in the context, and to ask yourself, what are the contexts that you're working in and what context are you acting out of? For example, are you rescuing or are you following your role? What's the family system like and what context are you acting into? And what contexts help you think and where do you find it difficult to think? Because that's probably telling you something about the system. What we see depends on where we stand. So developing resilience involves developing insight and an understanding of ourselves, our needs, our history, what we bring to the work and how we impact on people, and then matching that. When I do talks on resilience, sometimes I think people are hoping for tips and techniques and strategies, and yes, there are lots of tips, techniques and strategies, but I think the very first step is insight, and the second is good matching of your strategy to yourself. And what's also important is space and support to process the emotional impact of the work. So keeping resilience in mind, positioning, clarity about task, consistency, having some sanctuary, and having teamwork as a solace, a place to go back to revisit roles, to talk about the work. And coming back to intimacy and distance, we all need to be able to step away and then step towards, and to separate ourselves not just from the dynamics of the child and the family system, but the dynamics of the organisation, and to think about how that's impacting on us. And that's what I mean about separating the dancer from the dance. And most importantly, to be kind to ourselves and have some self-compassion. So designing work with children for resilience, keep the child in mind, in role, in relationship to other roles, to enable the system to cope with uncertainty, to treat the child, and also maybe to cope with loss and grief. I've written a book about this work called True Tales of Organisational Life, and one of the stories from the book I think is in your packs, and it's there because it was a good example of what you all know, which is that when working with children, you join the family system in a way to help the family system to take the next step in accepting reality, even if it's a reality that they don't want to accept. So thank you very much.
Thank you very much, Barbara. A very interesting and insightful presentation on resilience.